We would now like to invite Dr. Priya to give her talk on pediatric cardiomyopathy, genetic cardiomyopathy in adults, phase-based review. Dr. Priya doesn't need any introduction. Everybody knows she's the General Secretary of IACI, the life of IACI.
Thank you, Dr. Aparna. So basically, we have seen a presentation of pediatric cardiomyopathy. Here, what I'm going to discuss is about how this genetics influence our life and how they are there in they affect the diseases, and these are real case-based studies and what lessons I have learned. So basically, it is important to understand that genetics influence cardiovascular system in profound ways, and it is nearly 30% of premature death are because of genetic predisposition. And improved understanding will definitely help us to understand these diseases, and finally, this will reduce the rate of sudden cardiac death events. This, though we learn from the Western experience, it is important that our Indian experience is very important because there is significant variability in the genetic architecture. We are different in lifestyle, social influence. So though we acquire new knowledge from the Western literature, we definitely need to collect our data, and learning from our own experience is very important. So I'm just presenting few cases. So this was a patient with chest pain, elevated troponins, clinical presentation like myocardial infarction with normal coronary arteries. These are the patients who will go because of the chest pain. Every time they do the catheter angiography is normal. Finally, when they do this MRI and you see this subepicardial ring-like enhancement. So from morning, all of you have been seeing, and I think now the take-home message should be that ring-like epicardial enhancement should raise the possibility of suspicion of some genetic abnormality. And in this patient, the presentation was like Minoka, elevated troponins. So that is why there is increased values on T2 mapping. And what you see on the genetic testing, this is desmoplakin cardiomyopathy. So whenever there are more than 3 consecutive segments in a single short axis slice, think that it is abnormal. Think of arrhythmiogenic cardiomyopathy with left dominant disease. Clinically, it can mimic myocarditis, sarcoidosis, myocardial infarction. Original task force criteria of arrhythmiogenic cardiomyopathy will not fulfill, but it is important that we identify this patient, because this is how we can, this leads to an actionable event, because these are the patients they should be suggested for the primary prevention ICD device. Now the terminology is changing, and these are the recent guidelines from the ESC, which along with like how HCM, DCM, this cardiomyopathy is termed as non-dilated left ventricular cardiomyopathy. Important to understand, these are young patients. LV function is normal. They just have repeated episodes of myocarditis or in elevated troponins, and the terminology what they name is non-dilated LVC. And it leads to this diagnostic pathway where you identify this disease depending on the clinical presentation, MRI features, look at their ECG and arrhythmia, and in case if the genetic testing comes positive, this was the previous classification whether to call it as arrhythmogenic left ventricular or ACM. The new proposed phenotype based integrated approach, which mentions that this is a non-dilated left ventricular cardiomyopathy. Moving on to second case. So this was a doctor's brother. He was diagnosed as dilated cardiomyopathy, ejection fraction in ranging between 45-50. He was every year he was going for the health checkup, ejection fraction borderline reduced, but he never underwent a further detailed testing. Recently, when he had 2 syncopal attacks, he underwent cardiac MRI. Though the LV function was mildly depressed, incidentally we found this in case, if you can appreciate, there is this RV wall motion abnormality. So mildly depressed LV function, subtle RV segmental dyskinesia. And if you look at the late gadolinium enhancement, it is a ring, but it is not a complete ring. So if you can see, if you can appreciate, there is something along the lateral wall, something along the anterolateral wall, probably the infroseptal. Few part is spread. It is an incomplete ring of epicardial LGE. There was no increased values on T2 mapping, and this was the genetic testing. So there were 3 genes which are positive. And if you can see, 2 of them are likely pathogenic. So as Dr. Rajesh showed in his lecture, there is a phenotype based of this genotype phenotype correlation. And when you see an incomplete ring, that can also be a genetic cardiomyopathy. And look at this. So these are the patterns of LGE, whether it could be absent, whether it could be linear, it could be mid-wall, it could be subepicardial, it could be just RV insertion, it could be transmural or combination of both. And there are these studies which have actually done which genes are responsible for what type of cardiomyopathy. Again, so this is the genotype phenotype correlation, where in the Spanish they have seen 577 patients and 62% of them had negative genetic testing. And if you can appreciate, there is a ring-like epicardial scar, even a thin wall scarring in the linear stria in the septum, or it could be even without. So all these patients were actually proven cases of genotype positive cardiomyopathy. So this leads to a question that in case if the LGE pattern is so varied, what is the point of screening and how do we identify this patient? So it is very important, because once you identify the abnormality, you can only that particular gene, the cascade family screening is important. So for example, in this patient, filamin C was positive. The family members have to be just screened for that particular gene. We can have the targeted monitoring, and with advances, there will be some gene specific treatment which may be available in future. Early diagnosis, early treatment, few of the cardiomyopathies who have more risk for arrhythmia, probably we can help with the primary prevention ICD. So this is how you get the genetic testing report. So whenever it could be pathogenic or likely pathogenic, they are definitely abnormal. In between, you will have a variant of unknown significance. I will come to it, what does it mean? Or it could be just benign variant abnormality. It is also important to understand whether one gene or multiple genes are abnormal. Then it leads to a high polygenic score, and the patient with high polygenic score are definitely more at risk. So depending on the type of the gene, depending on the polygenic score, all this probably we put the patient into the more aggressive or more treatment may be required. Another patient, 22-year-old male, presented with chest pain, uneasiness, vomiting. So he was admitted to the hospital. He was treated as ST segmented elevated MI. Coronary angiography was almost normal. He also had history of COVID vaccination before 2 weeks, for which he was also worked up. So there was always a suspicion that is it a myocardial infarction, ischemic cardiomyopathy, or a vaccine-related myocarditis. But remember, he was young male, 22-year-old male. And just look at his heart. Dilated heart, poor function, and this was the late gadolinium enhancement. So initially this was reported as whether this was a transmural scar in the LCX or RCA territory. But this LGE pattern is not typical in a 22-year-old male with normal coronary artery. If you can see this, there is something in the LAD territory, something in the inferior wall, something in the lateral wall. This clinical picture was not going well, and hence he underwent a genetic testing, and see, it turned out to be a titin mutation. So basically, we have to understand that these genetic cardiomyopathies, they have a very clinical presentation, very varied type of clinical presentation. It could be arrhythmia, myocarditis, or mimicking like a myocardial infarction. But when you have this atypical presentation from the clinical abnormality, which is not matching the pattern of LGE, which is not limited to one coronary artery territory, think of the genetic abnormality. These are the patients which are more prone for second hit. So maybe patient was having some genetic abnormality. Maybe the COVID vaccination was like a second hit, and that is why it resulted into a hot phase of arrhythmiogenic cardiomyopathy. So it is important to ask for history of myocarditis in the families, or history of myocarditis in past, because they always have in cluster. So when Dr. Rajesh spoke about this PRKG2 mutation in the families, people would have some abnormalities. If you take a detailed history, some young patient with, young relative with sudden cardiac death, you may find some clue. And it is also important that all the patients who drink alcohol, or not all the patients develop peripartum cardiomyopathy, because few patients are just prone because of genetic abnormality. So when you have this genetic abnormality, it comes in phases like this, and that leads to double hit hypothesis. and hot phase presentation of arrhythmiogenic cardiomyopathy. So these are the patient with genetic abnormality which can have a secondary event which can lead to viral entry, replication, and finally leading to chronic phase like a chronic remodeling. So it is important to understand that this is how a different clinical presentation of genetic cardiomyopathy can occur. Another patient, this was actually a middle-aged mother. Unfortunately, she lost her son. Her son collapsed while playing badminton and he was admitted in ICU. He happened to be a relative of a very senior cardiologist and hence the entire workup was done. Son had PKP2 mutation positive. Mother was completely asymptomatic. But the genetic studies in the mother also came positive. So as you see, with this mutation, she has some RV segmental dyskinesia. RV function normal, LV function normal. There are just some segmental dyskinesia in the RV wall. So she was hiding this mutation, which was not clinically, she had no clinical symptoms or no findings because of that. But in the son who was playing badminton due to athletic activity or whatever, how people exercise makes this as a double hit, and then it happened in the son, and that is why this was the reason for the sudden cardiac death for the son. Moving on to the next case. So this was a middle-aged male who presented with symptoms of heart failure. And what you see on this cardiac MR is a dilated heart, hypertrabeculation, non-compaction. Again, catheter angiography was normal. So middle-aged male presenting like heart failure, dilated heart. So this was reported in other centers, and this was a pattern of late gadolinium enhancement. You can see a ring, but it is more in the insertion point, not complete, sparing the lateral wall. This was something unusual. And hence, when we worked him up with, so these are the long axis images of late gadolinium enhancement. Just see the extensive LG, probably going to the right ventricle as well. And the genetic testing again came out to be MYBPC3 positive. So this was probably a combination of left ventricular non-compaction or a DCM. So there is a significant overlap between different phenotypes. Dilated cardiomyopathy, HCM, because as you see in this specimen, how all the genes are related in a myocyte. So it could happen that what you see as a genetic abnormality is HCM, clinically looking like DCM, but presentation of some genetic abnormality with significant overlap in the phenotypic presentation. Another case, this was a 60-year-old male who presented with ventricular tachycardia, monomorphic VT on ECG. He presented to ER with uneasiness, palpitation. There was no angina. He was cardioverted. Catheter angiography was normal. And 2D echocardiography revealed some LV hypertrophy, and hence he underwent cardiac MR. And what we see on the CMR was just borderline LV hypertrophy. There was no other evidence of SAM or other abnormality. And this was the late gadolinium enhancement. So what you see is just there are patchy foci of LGE, maybe near the insertion point, but not classically looking like HCM. Elevated values on T1 mapping, interstitial fibrosis. But this was a genetic abnormality. So though LGE pattern was not significant like an HCM, as you see in this genetic testing, 3 pathogenic genes, of which 2 of them looked like HCM. So not all HCM are same. All HCM may not have the late gadolinium classical enhancement. They could be, this could be, they're more present with LVOT obstructions. So these are the multiple genes which are responsible for the hypertrophic cardiomyopathy. And there are 2 broad, relatively distinct population, and it is important to understand that this was the first clinical presentation like monomorphic VT, and this is how the genetic testing helped us to find out that this was a pattern of or typical presentation of HCM. Next case, this was a patient who was admitted in our hospital since last 3 hospital admission in last 2 years. So every time he used to come like uneasiness, reduced ejection fraction, catheter angio normal. So clinically maybe some global hypokinesia. He used to be treated as a stress cardiomyopathy, like a Takotsubo cardiomyopathy. He improved on treatment. He used to go back again. Another year he comes back again, and when he comes back for the 3rd time, we ended up doing a cardiac MR. So as you see on this cardiac MR, there is just mild global hypokinesia, and this was the pattern of LGE. So there is just some LGE near the anteroseptal wall, maybe near the inferior septum, not classical picture. But when we caught hold of his previous cardiac MR, which was done in other institute, he also had some diseases like some LG, some pattern of foci of late gadolinium enhancement here as well. But 2019 to 223, we can actually see how the LG has improved. So diseases can evolve, and RV insertion point enhancement is not always benign. As we have seen in that ESC article also, there are few genetic cardiomyopathies which only present with RV insertion point enhancement. So the clue is that it is not just the MR picture, the clinical presentation, family history, going through the entire picture and putting MR as a role as an adjunct and then coming to the final diagnosis. My last case is a young male who had no symptoms. He just came for a routine pre-operative health checkup, and this was the abnormal echo, and hence he came for the cardiac MR. And what you see on this MR images as if there are thinning and dyskinetic segments involving interventricular septum. Very bizarre appearance. It was like bulging interventricular septum, the abnormal right ventricle, and we didn't know what it was. Multiple aneurysms were there. This was the late gadolinium enhancement. It was involving septum, lateral wall, multiple small foci, and on the CT sections, it showed some amount of fat as well as some amount of calcification as well. And since it was not fitting into everything, we convinced him to do genetic testing, and this was the genetic testing which came as a cardiac arrhythmia syndrome. So more importantly, it is important to understand that how we start doing more genetic testing, these genes will get collected into World Bank. All the data, whether I do it in my center or you do it in your center, multiple centers, all genetic studies, they go and the data is registered into the data bank in the World Bank. And for example, we may have some genetic mutations which are positive in our country. They get selected and then they get from variant of unknown significance, they become into pathogenic or a likely pathogenic. So as you can see over here, this is the line which happens into the genetic testing report, that though it is classified as a variant of unknown significance, because there is lack of phenotype investigation. However, once you start doing it and more data goes from our country, our continent, then it goes as, and then probably we can have a change in clinical recommendation. So this is what I have learned. Okay, the more we feel that we know everything, but these different types of late gadolinium enhancement, it is very important to understand. And whenever it is not fitting into a clinical criteria, so abnormal clinical presentation, you can't explain the imaging findings. It is also important that we do genetic testing. Maybe we can get to an actionable plan for the high risk genotype, and that will reduce the sudden cardiac death and reduce mortality. There are advances in the genetics and with varied treatment. And we will have improved understanding of the disease, and we can help with reducing sudden cardiac death event. Final message is that India as a country has more diversity than other countries. So for example, in European countries, it is not easy. You can't differentiate, whether it is from a Scandinavia or a Brazil or, some other country. But in India, we are different in all the parts of world. So it is important that we are aware about this and we do more awareness and more testing. Probably that will help us in future. Thank you. Yeah. So we have one genetist, I think probably also is going to talk, so he can help us with more understanding.
Well, thank you, Dr. Priya. That was an excellent talk. I have one question regarding that patient who came with the monomorphic VT.
Yes.
What was his actually? He came with.
It was monomorphic VT, and finally, if you remember, there was no. It was just borderline LV wall hypertrophy, just 15 millimeter borderline. There was no significant LG. T1 mapping values were abnormal. So since it was not fitting into this, he underwent genetic testing, and it turned out to be HCL.
He was 60-year-old. No?
60-year-old, yes.
Actually, the arrhythmia came from the right ventricular outflow tract. I was expecting when you showed the MRI there'll be some fibrosis over there, but okay. I think nothing was there.
Actually, right ventricle LGE is probably there was. It's not always you get RV LGE on the MR images, so that probably could be there.
Usually, 60-year-old is very unlikely for a HCM to present. Usually in the adolescent and young age, so quite astonishing 60-year-old coming.
Sir, not uncommon. I think I've seen we see that it's not uncommon presenting for the first time like this, sir. I've seen couple of patients. What about you, Ashita? I mean,
I guess with more cardiac MRI being used currently.
yes, yes.
for
So
those
they do not, probably they are not diagnosed early. I think that clinically though they don't come. Yes, probably.
absolutely,
Yeah.
but then because I mean ECHO doesn't find the cause for LVS,
Yes.
they started sending for cardiac MRI and we end up finding it.
Any other questions from the audience?
I think all these genetic testings will give Dr. Pradeep a nightmare in counseling because he's the one who's going to counsel all these variants of uncertain significance.
Yeah,
So maybe
yeah.
he can enlighten us in the next one.
Yeah.
One question is there.
Ma'am, in the case where you showed some RV insertion point fibrosis,
Yes.
and phenotypically, I think there was some amount of hypertrophy.
So
I mean,
it was presenting like Takotsubo cardiomyopathy,
Okay.
presentation, like, just global hypokinesia and used to improve on clinical treatment.
Okay.
And then when he came back, it was just RV insertion point.
right.
But
So,
if it is not matching into the clinical picture, maybe then you should consider this as a possibility.
for the, so no, because many times we find that due to RV strain or some other factor, that insertion point LG, many a times we just let it go. But when to advise genetic testing, other than the fact that it's a young patient who has come in,
Yeah. So of course, RV insertion point enhancement is a very common, finding what we see in all our patients. But when it is not matching into the clinical picture, like for example, pre-presentations, stress cardiomyopathy, earlier it was not there, now it increased. RV insertion point enhancement, which was seen on at least 3 consecutive slices, both the RV insertion point and abnormal, clinical correlation, then I think that is how he underwent. So we are just one center, and this is just last 6 months experience, and we have just done around 40 patients in genetic testing, and all of them have given us surprises. So it is still we are learning, and maybe we'll have some more data. The purpose is that all of us, we start understanding and we start implementing, then probably we'll come to some conclusion. Yeah. Yeah.
So is there a workflow that you follow for who will undergo genetic testing and who will not?
So first thing is definitely based on, at least in my institute, it is based on the CMR and clinical criteria. Abnormal pattern of late gadolinium enhancement, which is strikingly abnormal, not fitting into some criteria. Then we try and convince, we take a detailed history about the clinical family history, the pedigree analysis, find out whether some relative had some, sudden cardiac death in a young relative or some history of previous myocarditis. Then we convince them and we do. So not all the patients actually undergo genetic testing. The cost is the limiting factor. But when we are explaining them that, maybe one genetic abnormality is positive in your case, your kids, your siblings will benefit, then they have to pay less for the cascade family screening. I mean, the cost in Indian rupees is 15,000 when you tie up with a genetic laboratory. But the family members, they can do it in 5,000 only for those abnormality. So then they are motivated to do it, and we have got probably like 4 or 5 patients, they underwent, preventive ICD. So this was the doctor's brother who actually had to undergo. Otherwise, he would have collapsed. You never know. But then he underwent primary prevention ICD. Yeah.
May I request Dr. Aparna to come and felicitate Priya?